Yeah, we are going again from medial to lateral, and yeah, no, we are heading toward the hepatic flexion. What I want to do is prepare this part of the colon to be divided. As a principle of general surgery, do the easy bits first, and then the difficult bits become a bit more easier. So this is the easy bit. The difficult bit is the terminal ileum. So that's our hole from the other side. Can you see it? That's a dissection from the other side. This dark bit. You can flip it over. You'll see me going through on the other side. Okay, go back. So I think we should be not too far from our dividing the now just relax on your hand. Let go. Actually, let go. Just rotate the camera the other way. Yeah. That's right, and look down now. So that's where we're going to be heading to cut our bowel. Yeah, we need to maybe a little bit more. We can do that whilst we are there. It's a big sort of a big bulky lesion. So it's a bit difficult to mobilize it, but not impossible. Right. Okay. Now what I want you to do is grab this. Now don't rotate the camera, my friend. Yeah, keep rotating it back. Right, hold on. Yeah, hold on that. Yeah, let go. That's how you want it now. Yeah, so you are looking right up. Why is it the cable up, isn't it? This is 30 degree, guys, isn't it? Yeah, just hold it like that. That's good. Yeah. No, don't do anything. We're just fine at the moment. Right. Okay. Come out with the camera. Don't rotate it. Just come out. Okay. Just go back up there. Find that bit for me. That's beautiful. Well done. Show it to me. I can't see it. That's very nice. Okay. That's perfect. Just stay there. Are you guys still with us in the audience?
Yes. Yes.
So we're just defining the top limit, which is there. I think I can put my stapler there now. I don't need to go any higher. Okay. Let's attack it from the medial side now. Look down. So don't rotate the camera. Okay. Somebody was asking me about the ureters and stuff yesterday. Everything is there. You don't need to look for it. Now the camera view is rubbish. All right, just hold it like that. Thank you. Could you take the side to side tilt off? Excuse me. Take the side to side tilt off. Put the right side down again. For laparoscopic surgery, it's very important to just keep tilting the table. Be aware of how the patient is all the time. A bit more, please. That's it. Thank you. Okay, look down. No, to the left. Yeah, that's no. Very disorientating laparoscopic surgery, so don't worry too much about it. Look up, yeah. So we need to take this bit there now, which is a vessel. There, you see that? So I just need to take that and go close to the bowel, this vessel there, right? Where is your hand?
Sir.
Yeah, just find yourself. Come on. You know where you're heading. You're heading to the sequence. Look down, down. No, put the camera down. Yeah, and hold the other side for me. Hold this lead. Now pull your camera out. Right. Look down and push. Look, your instrument is going to the liver. Put it to the right iliac fossa, then you will see it. Right. Go in to the right iliac fossa. Hold that. There. It's right there. Okay. I'm sorry, it's just a bit disorientating, so don't worry if I shout at you. There. Hold it like that. Don't pull too much in it. My view is gone now because I have to. Have you got it again?
Yes, we have got it again, but not the endoscopic view.
I hope that's the most important view, guys.
Is that the ureter that we can see on the right below your?
No.
No,
You can't see the ureter yet.
At 5 o'clock.
5 o'clock. No, just a bowel. I'll show you the ureter or try to show it if you want. It's underneath somewhere there. The ureter, look down. The ureter and stuff is down there somewhere. I don't normally try to see the ureter in the right hemisphere, but it's going to be down there somewhere. That's the psoas tendon.
Right.
So it's going to be somewhere down there. Pull the camera out. You go too close. That's the bowel. I'm just sticking close to the bowel. So we have. That's the ureter. That's somewhere over there. Look up for a second. Look up.
Right.
Look up. Yeah, so I can see. Go behind it. Let go on your hand. Let go. Look up. Up. Yeah, and look down. No, it's not working out, my friend.
Pull out the most slightly part.
Yeah, hold it up there. That's better. Now look down. Put your hand up. If you don't rotate it, if you just put your hand up simply, you will look down, won't you? That's what I mean. Look up. I'm just trying to create a plane. I know that we have cleared both sides. I just want to put my instrument behind it. That's the ureter there, right at the bottom. I think, look up. The instrument has gone right down up there, so you should be okay dividing it there. That's the instrument coming up. Look down. Work with me. Hold it up there. No, stay. Keep your camera where it is. Don't move the camera, please. There. Just hold that. That's the last bit of tissue that we need to divide. Okay, to get on the other side. Yeah. Agree?
Yes.
There. Okay. That's the other side. Okay. And we know that we are not. The ureter is right down, so I can cut that with impunity. Open the echelon 60, please. Look up. Show it to you. So that's where I'm going to divide the bowel. Yeah.
Yes.
Don't go in, please. Don't move the camera. I didn't ask you to do that. Hold it up there, please.
Not
Sometimes the
sedated
camera
camera.
moves with the operator as well, doesn't it? When you move things. हाँ यार blue use करूँ. Just बस इसको ready कर दो अभी मैं use नहीं कर. So see, I come right close to the bowel as much as I can, so there's no mesentery bleeding or anything like that. So this woman will try to bring out the specimen through the ileostomy site. So she has no cut at all right? So like the guy yesterday. So I'm just saying we'll try to bring the specimen out through the ileostomy site. So this woman don't have any cuts on her at all. The problem with that might be that this is a big mass. It's a thick mass, so it might not come out through the ileostomy site, in which case we might have to extend it. अभी मैं देता हूँ. In which case we might have to extend it a little bit, in which case she might develop parastomal hernia. But we will see. Come out and look down. Do you guys deal with parastomal hernias? Is it common here?
We do find it when we place it lateral to the recti.
There's the appendix from the other side. Shit is not a good word to use. Okay, hold it up there. So I'm just dividing as much as I can. We still have to do some work on the iliac side, don't we? So we have cleared the you got the anatomy there. We have cleared the ascending colon. Now we are going toward the ilium. Okay. Okay. Look toward the ilium now. This is just the appendix coming through from the other side. Look toward the ilium now, and pull your camera out. Out. Okay. So we need to go through this layer now. All right. Look to the right slightly. Okay. Let me strip the peritoneum. Look to the left. We said we will be coming down there somewhere. Look to the left and up. Yeah, without rotating the camera. Okay, so that's where we're coming. All right. So it's pretty clear now. Look to the left. Okay. Can you hold it there? Go back where you belong. Yeah, that's better. Area there. Okay, let's go up to the ilium, the bowel, the ascending colon. Let's divide the ascending colon. Let me take that. Pull out. Pull your camera out. Okay. Echelon, please. So you're going to put the echelon 60, which I normally use, familiar with the use of it. Pull your camera out if you can. Save as much as the bowel as possible. Just make sure it doesn't come out.
It will come out. It's just
Yeah, pull out. Come on, guys, just pull out. Just concentrate for a second. Sorry. I think the port is fine for the moment. Now pull out and show me. Give me a good view. That's better. Thank you. What? This is a brown. This is a blue cartridge, isn't it? Gul? The blue cartridge, yeah. No, is this a blue cartridge? Is this a blue cartridge? Yeah. Come out. You just come out. Yeah. No.
come out.
Yeah. No, that's fine. That's fine. Okay. Now give me a proper view. I can't see anything at all.
Okay, go here.
This is cutting it a bit transversely.
2 centimeter half out.
I just need to turn it a little bit. You can turn this instrument by doing this. That's much better. So I've turned it. Yeah, that's a bit straight. Now, yeah, I can't see anything. If you can't see, I can't see.
This is very close to my keyboard.
Yeah, that's the pressure. What's the yeah? You're kicking the tube, so pressure is not well spotted. Because the tube is kinked, there's no. That's why we are all collapsing on each other. Is there a leak? Yeah, that's it. That's your job to make sure none of that happens. Now I've got a stapler on the bowl, and we are struggling with it. Take it out and clean the camera. Take it out and clean the camera.
Since she's very emaciated, so can't we pull out this
Yeah,
this
we have.
slightly?
It was out.
Because otherwise he gets stuck.
It was pretty out. Yeah, it was.
It can't be as hard as this one is.
It is harder this one, yeah. But the problem is this is a cut down, so it easily slips out. This one is not a cut down. Right, let me go in and show that I've got a proper bit. You've got to think about the person who's going to be joining it together. So I have to have a good cut. Yeah, that's pretty good straight to me. Look down, show me the whole limit of my, yeah, that looks pretty straight, okay? So I think that's what I'm going to do. I'm going to cut it. Hold that. Yeah, go on. Help it. Well done. Yeah, squeeze it. Okay, let go. No, you're not doing it. Let me do it. Let go. No, just wait.
There's some tissue in it. No, that's outside.
Sohail,
Yes.
yeah, it's Fawad Musa here. I just wanted to ask you, earlier was thinking to take the mucus fistula out. Now I think you have decided to staple it.
Yes.
So what
I've decided to leave it in. I've dissected a little bit higher than that. I can still take it out. I'll show you why.
Yeah.
I'll show you how.
Yeah. Can I ask you why did you, I mean, what was the reason behind changing the decision?
I'll need another. Could you give me a refill, please? A refill, yeah. Changing the decision. To be very honest, there's no reason. I can still bring the mucous fistula out, or I can still leave it in.
Yeah.
No refill in the thing. The advantage is obviously leaving it in shortens the operating time. Even if I bring the thing is with this patient is even if I give her a mucous fistula, she will still need a full laparotomy to join it together, right? And if I leave this in, she'll still need a full laparotomy to join it together.
Right.
So it doesn't really make much of a difference.
Yeah, but generally, to my experience, and I'm sure the crowd will also agree to me, that whether for tuberculosis or for any something like trauma, when we are doing a limited hemicolectomy, I'm talking about open surgery, we usually either do a right hemicolectomy, we anastomose it if the situation permits, or we take both loops out, and we try usually avoid this sort of situation where we are leaving such a long loop of colon there.
Why?
So how's your experience with that?
No, I'm asking you why would you prefer to have a mucous fistula as opposed to a closed end? I'm genuinely asking you, yeah. Why would you, what would be the advantage in a tuberculosis patient?
Why say that again?
I'm asking
Yeah,
you.
yeah.
You said that generally with tuberculosis you would bring the two ends out.
Yeah.
So what would be the advantage of that?
Okay, okay. That would be actually, we get all sort of cases. You see, many times there is a case where there is a perforation, or sometimes there is peritonitis, something, or many times the conditions they don't permit, when patients' conditions, comorbids, you know, and etc. Things, when the things are not healthy inside or with the patient. In that case, I'm saying that we usually decide to leave, to bring the both ends out. But I mean, that's the option depending upon how healthy the gut is and what the condition of the patient is.
Yeah.
Otherwise, we would go for a hemiclectomy, considering that the blood circulation on the right side is better than the left. But obviously, we are not going to do the same on the left side, you know.
No, yeah, yeah. Okay, let's put all this back and see how much we need to do from here. Maybe we are ready to pull it out, yeah? And then you can do a little bit outside. Let me just watch it. Let me just do a little bit more here. Look to the left. No, don't rotate the camera. Just look to the left. Hold that. Like that. So I'm just dividing the mesentery of the terminal ileum, and then I'll be in a position to pull the specimen out. All right, let's attack it from the other angle now. Yeah, you stay where you are.
Okay.
From this angle. So hold it like that now. Could you give me your hands, please?
What do you call it?
Tip top. I keep calling tip top. We just call it tip. Doesn't matter. Hold it up there. Yeah, that's right. Open this up and open your jaws. Now pull your camera out. You're going in. Yeah, hold it up there. I'll fix it a little bit. Yeah, okay. Yeah, that's good. Look to the left now where I'm operating. That's nice. That's the anatomical view, yeah? Don't move the camera. Look down. Look down. Yeah, that's great. Okay, look to the left, please. Yeah, we're getting there now. Look to the left, left. All right, look up now. I think that's where we're going to come. This looks
This looks
back.
pretty much like
Yeah, this looks
that
like
part.
pretty much the part that we are coming. So let me just strip it and then we'll bring the specimen out. Look to the left slightly so I can, no, don't rotate the camera. There, like that, okay? Let me just fix your hand, I'll fix your hand in a second. And then we can have a better view. So we can see that our cut is gradually proceeding. We are nearly there. I think if I come through there, it should be fine. So I'll fix your hand for a second. Excuse me, can you hold that?
Yes, sir.
No, don't move the camera, please. It was just perfect. There. No, let go. Sorry, let go. My fault. I think it's just appendix is coming in the way. Yeah. I need to flip it back. No, don't go in, please. That's better. Can you hold it like that? To be very honest, even if I pull it out, I should be able to
Yeah, it
get
will
it.
be able to come.
Yeah. Anyway, we'll just. So the only reason I'm not doing that, my colleague here is asking me that are we in a position to pull it out. The only reason I'm not doing that, I'm stripping it as much as I can because I know we'll struggle pulling it out. And what we'll do, we'll end up making the hole bigger, and she will end up with a parastomal hernia. So obviously don't want to do that. I want to strip it as much as I can so it comes out, and then we can avoid giving her a parastomal hernia. I'll look up for a second. I think this bit will just divide outside. Look to the left. No. You're rotating the cam. That's better. Look to the right now, without rotating it. Just let go on your hand. Let go. Let's flip it over and see how much is left. Pull out. Pull the camera out. Out. Look down. Yeah. So this is the bit that's left. Just hold it up there, please. That's the view I want. Yeah, that's the bit that's left. Okay, I think we should be able to pull it out with a little bit of a, or maybe we should just take this vessel. Yeah, let me take that. A bit of a vessel there. Can you give me a bigger, the big LIGO show, please?
LIGO show 10 minutes.
कनेक्ट कर दो 10 वाला है कनेक्ट कर दो बस दिलीप कनेक्ट कर दो मुझे पढ़ाओ हाँ रख दो
Okay?
Yeah.
Thank you. Look, now put your hand down there. Let me help you. Beautiful. See how diseased this is. I think I'm cutting through the disease at the moment. They're nearly onto the bowel there. That's all very diseased.
Maybe we should stick with the 5 mm.
No, maybe we should just pull it out, I think.
Oh yeah, that.
Yeah, let's do that. Okay. Let me just grab this bit with your, so we don't lose it like we did yesterday.
There was some bleeding from the edge we cut, the step root, the proximal.
Let's not do that. We'll have a look at it in a second. I bet it's a big, thick lump. We will struggle. I'm just using this as a retractor. I bet we'll struggle pulling it out. I'm just saying to my colleague, if anybody is left in the auditorium, that we will struggle with pulling this out. It's a big lump. Okay, so if you can hold that, then locked, yeah, it's locked. Okay, so top lights on, please. Yeah, I will have a look. It's okay, it's dry.
You want these out?
Yeah, I'm off my way, yeah.
Full on.
Have you got an external view now? I think they've all gone home.
Yeah, maybe.
Yeah.
Probably, yeah.
Yeah, this is like way past our bedtime.
Okay, diathermy, please.
Can you keep my camera?
Yeah, you can take the camera out. Yeah. Diathermy is ready? Yeah, what is cut and cork?
हमारे गॉस दे दो please.
So basically, you give the stomas according to the belt line. You take the camera. You give the stomas according to the belt line of the patient. All right, where the belt sits.
Okay.
She's a thin lady, so I would say anterior superior spine, pubic tubercle, umbilicus, something there would be fine for her. Then she can come underneath, and she probably wear her shalwar over there. That's probably she wear it.
Yeah.
So you don't want to put it right where the shalwar will sit. It either need to be low, which is very low here, or need to be slightly high, so she can. Oh, that's you. She can put it down. She can look after her stoma back. So I think somewhere there would be fine. Lights on, please. Lights on the.
Light.
Just give me Little Woods, please.
Yeah. Can I?
Little Woods.
Just for step.
Just give me a Little Woods. No, yeah, Little Woods. Stop. Little Woods, yeah. You know the instrument with the something like that. That's a. Don't confuse him.
I'm sorry. My bad.
No, someone is taking the diathermy off.
Asif, diathermy check करो. Diathermy is not working.
Yeah, fine. Let's put the light a bit more on the target, please.
Right. Let's see top light here.
Couple of Langenbachs too. This is a very small hole. But what, I mean, we'll see. I mean, in a situation like that, wound protector would have been ideal. Absolutely ideal.
It stretches the.
Yeah, she's getting a bit tight, guys. She's breathing actually. She's beginning to breathe.
So we are making doing a elastomy and mucosal.
No, I'll elastomy, leave the stapled end in. Yeah, you can reconstruct it. Why? Have you got, what are your thoughts?
Because I was thinking if she went for a minimal invasive surgery for a major part of her disease, and to suture it back, she would undergo a laparotomy.
Yeah, that's a good thought. But even if I give her a mucous fistula, a separate mucous fistula, you will have to mobilize both of them, and then you need to visualize it. Even then, she will require a laparotomy, won't she? How do you join mucous fistula ileostomy? The only way I can do it is bring both ends out from the same hole.
Yes.
But even then, I never feel comfortable. The only time I feel comfortable with doing ileostomy closure is if it's a loop stoma. If it's two ends, I never feel comfortable joining them together. I always do a laparotomy to see properly that there's.
What we do,
What do you?
लार्ज कोलन आता है वहाँ तक ठीक है, ईडियम जो होता है वो तो मोबिलाइज होता है ना, वो तो ऊपर तक जा सकता है.
But you are absolutely right. It's a good thought, and I thought about that as well. But we'll see. Right, scissors, please. Scissors. Thank you.
Just need to force it.
No, it's okay. Just pop your hand on the Langenbach. It's
Inside?
okay. Yeah, inside now, please. No, it's going to be a job and a half actually to bring it out through this hole, but we'll try. Babcock, please. Right, just feed it through in there. Is that you?
Yeah.
Okay, let go. Yeah. Just give me a soap with betadine on it. Give me a swab with betadine on it.
Red gone.
Yeah, take it out.
Take it out.
Sir, one question.
Yes.
What you learned from this case?
What I have learned from this case, yeah, lots about tuberculosis.
Should I take one out?
I
So
know.
now you would be able to say I have experience of operating on a tuberculosis patient.
It's what?
It might just actually come from there.
Yeah, it might do. You're right. But we'll see. I think this is the easy part, isn't it? That was the
That's
part.
the collapse.
Yeah. The hard part is
Still down there.
the hard part is still down there. That's why I asked the anesthetist to relax it. Just take one out, please. The hard part is still down there. Just hold that for a second. Yeah, hold that, please.
Blade.
Is that from that edge that I've just cut? Yes, from there. Just swab that. No, swab that edge
Okay.
of the muscle.
I need to see that.
Yeah, no problem. What's that? Don't press that. Oh no, is it from the bowel or where is it? Yeah, just clean it.
The forceps.
Yeah, just hold on, guys. It's a massive mess.